This programming is brought to you by Boehringer Ingelheim Pharmaceuticals Incorporated. Heart failure guideline-directed medical therapy offers an opportunity to provide better care for patients, but significant gaps in uptake remain. Now more than ever, it's time to pump up GDMT for heart failure. Leaders in the cardiology community recognize this need and are asking you to do the same. Visit pumpupgdmt.com to learn more. Together, we can help ensure guidelines are enacted and patients receive quality care.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hi, everyone. My name is Gurleen. I'm a cardiology fellow at Brigham and Women's Hospital, and I'm really excited to be here tonight with Dr. Rachel Goodman, cardiology fellow at Tufts Medical Center. And this is a very special episode put together in the context of the new 2025 ACC/AHA Acute Coronary Syndrome Guidelines. And to get us started, I'll turn it over to Rachel to tell us more about who we have with us tonight and introduce our guest experts, but really looking forward to the discussion.
Thanks, Gurleen. I am very excited to be here tonight. I have been nagging Dr. Navin Kapur for almost 2 years now to do something with us on CardioNerds, so this is a great moment. I know you all know Navin, but I'm going to introduce him anyway. Navin is really the ultimate cardio nerd. He is a professor here at Tufts, where he works in the interventional cardiology and heart failure arenas. I am going to read you a list of all of his titles here because I did not know that he held all of these titles until now, but he is the Director of the Acute MCS Program, the Executive Director of the Cardiovascular Center for Research and Innovation, the Director of the Interventional Research Lab, and the Director of the Cardiac Biology Research Center within the Molecular Cardiology Research Institute at Tufts. Navin, as you all know, is also a pioneer in the cardiogenic shock space. And I think especially pertinent to tonight, he is really a pioneer in LV unloading. On a more personal note, I'll say that he is a wonderful mentor and attending. And I've spent, honestly, countless hours with him in the lab and in the unit just learning. We are so happy to have you here tonight, Dr. Kapur.
Thanks, Rachel. I appreciate that. And it's a real pleasure to be with the CardioNerds tonight. The Shock Working Group is representing. We've got some of our best here with us tonight. With the entire steering committee is a group of fantastic individuals, leaders in the space. And Shock Working Group, for a long time, our mission is really to educate folks about cardiogenic shock, a devastating condition for which we are still seeing high mortality rates. The premise of the Cardiogenic Shock Working Group is built on the concept of generating data to support our observations and our hypotheses. The working group has crossed over 14,000 patients in the registry, accumulating about 3,000 to 4,000 new patients each year at about 43 sites across the United States and outside the United States. So we're thrilled to be with CardioNerds tonight. I know the CardioNerds mission is very much aligned with educating folks about really sick patients and their conditions. So excited to join you all and looking forward to the discussion. Thanks for having us.
Thank you so much, Dr. Kapur, for all your work and for everything that the Cardiogenic Shock Working Group has done to really generate evidence in our field. And we're so grateful to be able to learn from some of you here tonight. We're also joined by Dr. Shashank Sinha, who is an advanced heart failure and transplant cardiologist at INOVA Fairfax Medical Campus, where he serves as the medical director of the Cardiac Intensive Care Unit, the system director of the INOVA Cardiogenic Shock Program, and director of the Cardiovascular Critical Care Research Program. And we also have Dr. Rachna Kataria, who is an advanced heart failure and transplant cardiologist with the Brown University Health Cardiovascular Institute. Her research interests include management of cardiogenic shock with a focus on temporary mechanical circulatory support and building collaborative networks of cardiogenic shock care. So Dr. Kapur, Dr. Sinha, and Dr. Kataria, such a pleasure to have you here on CardioNerds, and we're really excited for the discussion and to learn a lot from you all tonight.
Thanks so much for having us, and really excited for this opportunity and looking forward to our conversation. Yeah, excited to democratize cardiogenic shock, just like everything else you guys have democratized. I love that.
Before we dive into our case for today that will kind of ground our discussion, I just want to quickly review why we're here. The 2025 guidelines for management of ECS has made LV unloading with a microaxial flow pump a class 2A recommendation in patients who have an ST elevation, MI, or severe refractory cardiogenic shock. In doing so, it also downgraded the use of an intra-aortic balloon pump and ECMO to class 3. So we'll talk about all of this as we go, but hoping that just for some background, Dr. Kapur, can you kind of tell us more about the evidence that led to this change?
Yeah, absolutely. So this change in the guidelines is historic in nature for several reasons. One is it's based on the first randomized controlled trial in the field of cardiogenic shock that achieved a positive primary endpoint. That has never happened in the history of cardiovascular humankind. So that's really why it's really a landmark moment. Prior to that RCT, as there were a number of trials that have attempted to try to target cardiogenic shock using both pharmacologic approaches as well as strategy approaches such as revascularization and also testing mechanical support devices, which we consider part of our arsenal in terms of managing cardiogenic shock. There's been a lot of debate over the past 15 years about the MCS shock trials, and IABP shock 2, ECLS shock are the two most well-known. And they both tested the concept of routine use of intra-aortic balloon pump or VA-ECMO or AMI cardiogenic shock. And they included non-STEMIs and STEMIs, included out-of-hospital cardiac arrest, prolonged resuscitation. So really quite a mixed bag. And not surprisingly, those led to neutral results for those trials. I think most folks have interpreted those trials as limited in their impact because they really focus on routine use. The DANGER trial, however, really flipped the script. They used very prescribed use of a transvalvular flow pump because MAFP is actually a misnomer. These are not actually microaxial flow pumps. But I will say that basically the DANGER investigators really focused on a specific target. They decided to go after patients who had univentricular shock with a univentricular support strategy and focused on early support, meaning ideally pre-PCI support, which a fair number of the patients who were enrolled in the DANGER trial had. And so I think by doing that targeted approach, they were able to really test a very specific hypothesis. The other thing they did was they learned from their clinical practice and they learned from previous failed trials. The original shock trial had a negative 30-day primary endpoint, but a positive 6-month endpoint. And that was the rationale for Jacob Muller and his team to use 6 months as the primary endpoint. The second thing they learned from was the use of sky staging. They implemented the shock working group sky stage. They looked at lactate. They looked at escalation. They looked at echo and hemodynamics. They did all the things that a cardiac critical care person would do in terms of optimizing care. Their result was positive with a number needed to treat of 8. And if you're under the age of 77, then the number needed to treat was 5. The other key observation was that they did observe high rates of adverse events. And the asterisk in that comment is that this was an investigator-initiated study. So the definitions of those adverse events were not as clear. And so there's lots more studying to be done. But it took 10 years to enroll the trial. A lot happens in 10 years. The technology evolves, many things change. But despite that time frame, they were still able to achieve a primary endpoint that was positive. For the class 3 downgrade of balloon pump and ECMO, I think it's really important for all the nerds out there to read the guidelines very carefully. And that means you got to get a magnifying glass out because when they ask you the question on the boards, it's going to nail the footnote. So I would read the footnotes because what they really are downgrading is routine use of intra-aortic balloon pump and ECMO. And that's based on the RCT data. This is a class 3R recommendation, which means randomized. That's the highest level of evidence. So it's very powerful. And it's also a class 2A R recommendation randomized. The level of evidence supporting the guideline is actually amongst the highest. I still think there's a lot of work to be done. Shock Working Group and all the nerds out there need to partner together to advance the field with more data, more either randomized trials or smartly done prospective studies. And that's one of the major objectives of the working group. So maybe that gives a little bit of context for the guideline change.
Thank you so much for walking us through that. And I just finished up a week in the CCU last week on nights. And so all of this discussion of MCS and how limited data sometimes has been in this historically in this realm, and how danger shock has really provided us with a very different sort of trial is very relevant to the patients that we take care of in the CICU. With that, we'll get started with the case. So our case is a 68-year-old woman with no cardiac history or risk-enhancing factors who presented to an outside hospital with an inferior STEMI. She was taken to the cath lab where coronary angiography showed that the RCA was a single coronary artery perfusing the entirety of her right and left coronary systems with a 99% thrombotic mid-RCA lesion, which was intervened upon with a drug-eluting stent. She was then loaded with oral prasugrel. Her LV-EDP in the cath lab was 26 millimeters mercury, and she was given 120 milligrams of IV Lasix at that time. During the case, she required vasopressors, which were able to be discontinued after she got the intervention. But soon after the PCI, she became tachypnic with concern for flash pulmonary edema. She didn't tolerate BiPAP and subsequently had to be intubated. The repeat ECG afterwards demonstrated inferior ST elevations. So she was taken back to the cath lab with the coronary angiography demonstrating acute stent thrombosis, which was treated with thrombectomy and resulting TIMI-3 flow. An amtifibidide drip was started and an intra-aortic balloon pump was placed, and she was then transferred to a tertiary care center for further management. Dr. Kataria and Dr. Sinha, any thoughts off the bat about the management in this case? What are your thoughts and reflections hearing about her initial course?
Thanks, Gurleen, for getting us started with the case. I'm so glad we picked this case because, as we've shown in the shock working data from multiple centers, 50% of our patients that we take care of in cardiogenic shock at the quaternary centers, VAD and transplant centers are transferred in. So this is something that we're commonly seeing as a patient that was initially managed at an outside hospital, then gets sent into a quaternary care center. I would also add that needing pressors equals to being in cardiogenic shock. And I think that's important is because as we start calling this cardiogenic shock, it changes your mindset, right? So if she needed pressors during the PCI, she was in shock, and that would change the way that I temporarily assess this patient. And it would also just change my mindset. And I know that this is a high-risk patient to begin with. So those would be a couple of things to keep in mind. As far as onset of shock, it's really hard to know when shock started. But I think what we can do better is classifying severity of shock. We have the Sky Shock staging, the CSWG Sky Shock framework, the shock definition. So I think we can do a lot better at characterizing these patients in shock. If a patient's on pressors coming in with a STEMI and they're in shock, maybe use a SWAN to better understand if this is univentricular, biventricular, and kind of go from there. So those are just some initial thoughts I have as I'm listening to this case.
Yeah, I agree with all those considerations that Dr. Kataria eloquently articulated. Time is our most precious resource in preserving muscle and organ for our patients. Being able to classify the Sky staging for this patient in real time and recognizing its dynamic, and also recognizing that data from the shock working group has shown that 90% of Sky B and 70% of Sky C escalate to a higher Sky stage during some time during their index hospitalization. And when they escalate, their outcomes are worse. And so maintaining a high level of vigilance about, did this patient actually achieve their therapeutic result? You didn't share what the result angiographically from a TIMI-3 standpoint was. Clearly, there was in-stent thrombosis, and so we had to go back to the lab. I think highlights the importance of making sure the technical considerations, an elevated LV-EDP prompting, perhaps a PA catheter being placed, understanding whether you've got biventricular dysfunction and is additional hemodynamic support needed at that time. And then making sure that you've got the appropriate cardiac critical care support, as I'm sure we'll discuss in greater detail, are all important considerations in the initial golden hour of acute shock.
So to keep going with our case, upon arrival to the tertiary care center, she was on norepi 0.38 mics per kg per minute, phenylephrine 1.4 mics per kg per minute, and vasopressin 0.06 units per minute. She had a creatinine of 1.6, an AST of 650, an ALT of 95, and a lactate that was between 3 and 4 and rising despite her balloon pump. She had evidence of limb ischemia on exam. A swan was placed pretty quickly, and she had elevated biventricular pressures, and her index via FIC was 0.9. This was all on the support that we previously mentioned. So dobutamine was added. Pretty quickly, though, the decision was made to escalate, and she was cannulated for VA-ECMO and then had an Impella CP placed for unloading. The balloon pump that she had was removed.
Thanks, Rachel, for walking us through her course afterwards. And I know we talked a little bit with Dr. Kapur about MCS and the randomized trials in this arena that they've been challenging to conduct because there's a relative lack of equipoise by treating physicians, which leads to selective patient enrollment and may limit generalizability when we're thinking about these devices. But we do have the Danger Shock randomized trial that enrolled patients with STEMI and cardiogenic shock that was less than 24 hours in duration in 14 centers in Europe and randomized them to the microaxial flow pump or standard of care. In this trial, we saw that there was a reduction in all-cause mortality by 26%, which translated to an absolute risk reduction of 12.7% and a number needed to treat of 8. But there was increased risk of complications like bleeding, limb ischemia, and renal replacement therapy with the microaxial flow pump. How do you contextualize this case that we just discussed in the era of danger shock? And we know that the guidelines, we have to be careful about the fine print and how they kind of specifically mention these MCS devices. And the guidelines say that microaxial flow pumps in STEMI cardiogenic shock is for quote-unquote selected patients, with an emphasis on selected here. So what makes a patient a good candidate for a microaxial pump, and what are the caveats?
Well, thank you, Gurleen. And there's clearly a lot to unpack here. So I'd like to begin with a quick detailed overview of danger shock, building on what Dr. Kapur shared with us earlier. Anytime we're trying to apply clinical trial data to our patient at the bedside, we have to ask, well, what patients were included in the RCT? There were 355 STEMI cardiogenic shock patients, unfortunately 80% of men, mean age around 66, with LV dominant shock, an LVEF less than 45%, a lactate greater than 2.5 millimoles. The mean, I think, was around 4.5 in both the control and intervention arms. A systolic blood pressure less than 100. And then importantly, no comatose cardiac arrest. There were still about 20% who did have some cardiac arrest, but a GCS greater than 8. And it was obviously across a number of sites. You mentioned 14 across Denmark, Germany, and the UK, with very little crossover. What we're really proud of, it was among the first trials to first formally apply our modified sky staging from the CSWG. Using that criteria, more than half of these patients had sky C shock at the time of enrollment. For those reasons, because it was studying such a very specific patient population, we should applaud the steadfast commitment of Dr. Moeller and the danger investigators to the protocol. But it took, more than a decade, and it was a landmark trial for that reason, and the first positive RCT we've had in nearly 3 decades. Strictly speaking, I'm not sure our patient would meet these IE criteria, right? There was evidence of biventricular shock. As Dr. Kapur noted, nearly 80% of these patients were done pre-PCI or in the cath lab. And invasive hemodynamics were obviously performed, well after the fact. And then there was escalation to VA-ECMO for Sky E shock, I would say in this case, with Impella CP for LV unloading. Importantly, in the trial itself, about 20% of patients did require escalation to VA-ECMO, so it was not uncommon, but I'm not sure that our patient necessarily meets danger criteria, but I'm curious to hear what Drs. Kataria and Kapur think.
Yeah, I'd agree with that. In fact, I think that this case illustrates the importance of the term guidelines. At the end of the day, what we really need to do is cross-reference the evidence base with our understanding of the pathophysiology of the patient and the mechanical physiology and mechanical efficacy of the therapies we're applying. So use of an intra-aortic balloon pump in this case is probably mostly driven by resources and what's available at the hospital. This patient had a very unusual coronary anatomy where by obstructing her mid-RCA, she immediately created anterior and lateral wall ischemia of the LV and also had RV involvement. I think that's a very unique presentation because now if they were to strictly apply the danger criteria, they'd be checking boxes and trying to make sure that, well, does it fit or does it not fit? And this is why they're called guidelines. At the end of the day, the use of an intra-aortic balloon pump, you won't be faulted, but if you stop and actually observe what happened, this actually likely represents TIMI 1 flow after successful PTCA of a thrombus and distal showering emboli into the microcirculation. When you have that type of event in someone who is also in heart failure with a high LVDP, putting an intra-aortic balloon pump, you'll increase the diastolic pressure, and that augmentation is designed to try to increase coronary blood flow through integrated arterial perfusion. And during ischemia, autoregulation at the microcirculation is uncoupled. The problem here is you have a thrombotic obstruction in the microcirculation. So actually, the only way to reduce the ischemic burden is to reduce the LVDDP and to reduce pressure volume area. And so that's where a transvalvular pump may be able to achieve that. We as physicians have to sometimes operate based on our understanding of pathophysiology and the therapeutic efficacy of our choices. And so I think that's where this becomes a very challenging case, a unique one. The most important things I would say here, just to sum up my comments, are one is a PAC wasn't inserted until after transfer. You've now got someone on triple pressors and no PA catheter. So if you're going to use pumps, use PACs. They go hand in hand. Because I think if they had put in a PA catheter, they would have seen the cardiac index of 0.9, and that may have triggered even more rapid escalation. But they did the right thing. They got the patient transferred out of there. They didn't stay in the hospital and ruin the golden day for this patient. The second thing is that on arrival, what we often see is stable mean arterial pressure on 3 pressors and a balloon pump. And often people are fooled because the balloon pump augments diastolic augmentation beautifully, but that doesn't correlate with that cardiac index of 0.9. And the lactate not washing out. So if you do not achieve lactate washout, which means it comes back to normal, as opposed to staying at 3 or 4, that's not lactate washout, then that's another reason to escalate. And so some of these best practices still need to be very much studied and implemented in clinical practice. But that's how I interpreted this case. Very difficult one. The operators can't be faulted, and they did the right thing by getting the patient transferred to a center that could escalate quickly within that first 12 hours.
Yeah, I think that was such a great summary, Shashank and Navin. It highlights what we said in the beginning. Nothing about shock is routine, right? This case just highlights that. Nothing about shock is routine. And those of us who manage shock routinely know that. So I think it's really important to remember. It was one of the first lessons I remember from residency when an attending of ours, Dr. Ajapong, was teaching us how to critically appraise literature. And he said guidelines are meant to be guidelines. They're not something that you live by. That's guidance. That's a yardstick at best, but not something that you must always comply with because your patient will never match exactly what the guideline is describing. So yeah, the case highlights all of those things beautifully.
There's a lot of talk about IABP shock 2, ECLS shock, and like how these are negative trials, but there's a lot of patients that I think benefit from these types of devices, ours included. And I guess I'm wondering how you can contextualize that or use that in your clinical practice.
I mean, I think the challenge here is that this patient went from a balloon pump to VA-ECMO to Impella. And luckily, that patient threaded 3 needles to get to a point where they could get lactate washout. And so the point is that as we get more sophisticated in our understanding of cardiogenic shock and the technologies and therapies, our risk prediction models become more sophisticated. Our critical care capabilities also become more sophisticated. We're going to have to get to a point where each center has an algorithm that they implement that allows them to escalate care in a timely manner and efficiently. And when I say efficiently, I also mean cost efficiently, because if you think about it, the balloon pump leading to limb ischemia, delaying care, this patient could have died 3 or 4 different ways actually before they even got to the receiving facility. So there's an immense amount of work to be done. Danger because of its positive finding I think will have an impact in the community, where community physicians will start to need to learn how to unload the LV and how to do that safely. ICUs in the community are not equipped currently to handle that. They can't handle a PA catheter. As you saw in this case, they didn't put one in. And so we have to come up with a better system of care. In the meantime, though, patients are dying, and there are a subset of STEMIs that will meet the danger criteria. And our operators, which I empathize with, a lot of the operators who are not quite facile yet with transvalvular pumps, they're going to need to learn how to do those. There's also a new generation of operators that are coming out that are very comfortable with these types of techniques. And so I think that's also where community centers will start to rely on the new crop of operators and how they can handle these types of cases. Shashank, I'd love to hear your comments about systems of care relates to the network and how do we get better at this instead of the inefficient escalation stepwise and having delays and expense with AEs as well as finances.
Yeah, so much to unpack there, and obviously appreciate the question. I think first and foremost, actually, advice you had given me a very long time ago when I was a fellow in training, which was that pumps pump blood and people save lives, right? And so if you look at least the 2022 ACC/AHA Heart Failure Society of America guidelines, there are only 5 recommendations for shock. Only one is a class 1 recommendation, which is the use of IV inotropes. But the rest of them are class 2 recommendations. But one of them is a class 2A recommendation for the use of the multidisciplinary shock team. We've obviously contributed data to that. A number of other multi-center registries have also contributed some evidence generation there. That not every hospital, and certainly not even every level 1 center in the country, has a shock team. Now, we can get to whether that is cost effective. There's some data from Stavros Drakos and his group at University of Utah to suggest that it may be. But in terms of the actual implementation, I think the journey of shock that these patients take, going through multiple temporary support devices and their attendant complications, survival isn't our only goal. Our goal is actually for them to thrive long-term. And the morbidity that they subsequently carry is not insignificant. And I think we're going to discuss that in greater detail. So I would say from a systems of care standpoint, at the very least, every community hospital, level 2 or level 3 center should know who their level 1 referring center is and have a call early, call often, and a serial reassessment to discuss these patients. And where I really applaud the team was, yes, while they didn't perhaps place a PA catheter or recognize that this was biventricular shock, they did know to call for help. And they did transfer to the appropriate institution where timely assessment and therapies were implemented. And we'll continue to customize that. What the trials were lacking, and if I can lament briefly with this group, because we are all nerds, Recover 4 was going to be the first trial in the US to really test this strategy in an American population, but to actually have a protocolized ICU pathway. And there are some best practices there that we've developed through anecdotal experience. Maybe there's some observational evidence to support some of them, but really have never been formally tested. And I think that's where, as we think about clinical trial design, hopefully it doesn't take another decade to generate that level of important data for this vulnerable patient population. But we really need to be more thoughtful about it, testing care pathways and algorithms as we do in various shock teams throughout the country.
Yeah, so I'll just comment that Shashank and Saras as well are writing up the R4 protocols. I think we have it due in 1 month from those guys. So the shock working group is working aggressively. But actually, when that paper comes out, it's really important to understand that part of the reason why I think R4 could never get off the ground is because of how sophisticated the algorithm was if you actually implement best practices. I would say right now, 90% of centers in the United States cannot implement best practices for cardiogenic shock. They simply can't put in a transvalvular pump. They can't put in a PA catheter. They can't manage or interpret the PA catheter in the ICUs. They can't escalate in a timely manner because what do you escalate to? You escalate to right-sided support. You escalate to VA-ECMO. You escalate to 5.5. These are technologies that are not widely available, and they require intense expertise to be deployed safely, and it requires a team and systems of care. So that was the R4 algorithm. And in fact, there are very few centers that can execute it to the way it should be done. So we have an immense amount of work to do as a system. And that's why all the nerds who are listening should really take the lead, because that's the next generation of leaders who actually come up with these systems. The current generation has been generating data around the MCS platforms, understanding physiology and all of that. But now comes the time to implement in systems. So I'm really excited to see what the next crop of nerds does over the next decade with systems of care.
Thanks for that great discussion. I think that point about systems level change is really important because now we have some data, we have guidelines, but it's all about implementation and how we go about doing that. And I want to go back to your earlier mention, Dr. Sinha, about the role of critical care cardiologists in this. And it's a very interdisciplinary field of the shock teams. Not all of these community centers have people trained in the interventions, like Dr. Kapur mentioned, but they also don't have critical care trained cardiologists who are trained in managing PA lines, or even the nurses who are trained for what to do with troubleshooting and other aspects. So I would love to hear all three of your thoughts about what does this kind of mean for the field of critical care cardiology, and how should we go about improving the implementation of these therapies and having more providers at various centers capable of providing that expertise?
Well, thank you for that important question. I think there's a lot that we can note there. One is that it's a numbers game, and we simply don't have enough critical care cardiologists either currently in practice or that are training in the pipeline to pursue this, because we need your help in being able to staff just level 1 CICUs around the country. Recognizing the point that both Doctors Kataria and Kapur made earlier, as did both you and Rachel, that the majority of shock care is actually in the community. And we need to figure out best practices all around it. It's not sufficient to just be able to implant and ship. That is not an acceptable strategy in 2025 and beyond. We've articulated some important themes about what the organizational structure, staffing, training, and care delivery models look like in a recent scientific statement that was published in Circulation and will be reprinted in JACC. It's trying to provide organization, as the title infers, on how we should appropriately pursue optimal outcomes for our patients in a level 1 CICU. And if you don't have a critical care cardiologist and are unable to hire one, then you absolutely need a collaborative model between a cardiologist and an intensivist with requisite experience in not only temporary support, but in the prevention, recognition, and management of all the complications. The composite safety endpoint was 24% in the intervention arm as compared to 6% in the standard of care arm. But if you really drill down on the AEs, 2-fold higher risk of moderate or severe bleeding, 5-fold higher risk of limb ischemia, 2-fold higher risk of renal replacement therapy. Although among survivors at 6 months, none of them required dialysis. And so we're learning a lot more from the study as long-term outcomes emerge from this very important landmark trial. But clearly, one of the most sobering and important aspects of the study is that critical care management is absolutely sine qua non for the care of these patients. And that's why it really takes a team. There's no one individual that can play hero ball and save lives. In the most complex cardiovascular conditions, the same holds true here. And I'm very proud of the team that we have at Cardiogenic Shock Working Group, and equally proud of what we're able to do for the care of our patients.
I'll add to that because a passion of mine is really that the collaboration between networks. I happen to be a part of Navin's network. I have other hospitals in Rhode Island that are network hospitals to Brown. And a lot of the phone calls are often confusing, right? You're receiving these patients and the transferring institution isn't even able to describe to you what exactly is going on. They just need help. They just want this patient transferred to your CICU. And we all know that we're always in a bed crunch situation. So a lot of the conversation ends up being on the phone, trying to understand what's going on and trying to provide recommendations. Shashank, Navin, and I are part of the ACC clinical consensus guidance, again, led by Shashank, where we emphasize actually on just the art of suspecting cardiogenic shock, right? That's like half the battle won. If you've simply suspected cardiogenic shock and called it such, and then called your network hospital. So you have to identify a network hospital that you then call and say, I have someone in shock and this is what I'm thinking. Would you do something differently while you make a bed for my patient? Or you say this can be managed at your institution and these would be my recommendations, et cetera. And let's keep reassessing and discuss the need for escalation. I found myself in that situation with Navin where I'll give him a call and I'll say, I have a patient. hopefully I'm doing a better job describing them, sky severity, and then phenotyping, hemodynamic profiling. I feel comfortable managing them. Do I need to send them to Tufts? And often the discussion is, no, hang tight. We'll keep temporarily reassessing and keep the conversation going. So I think although at level 1 centers, there's the heart failure cardiologist and the critical care cardiologist, I think a lot of the community centers still need a lot of help and education about just suspecting shock and getting the first few steps started. Identifying a shock champion, something else that we learned about as we held this expert consensus roundtable discussion around cardiogenic shock, was maybe identify a shock champion at these community centers, someone who's interested in cardiogenic shock. And their sole focus would be to identify shock and help stabilize those patients so that we're not simply implanting and transferring and then causing a whole lot of AEs in the process.
Thank you. It's been a really insightful discussion as we started to unpack the case, talked about the guidelines, the trials, and also the system level changes that need to happen to really implement the guidelines. And with that, we'll turn back to our case. So Rachel, what happened to this patient that we were talking about and discussing?
So her shock, as we said, was biventricular. So given that, as opposed to informal ECMO turn down, she underwent a formal bridge trial to allow for assessment of her hemodynamics when completely uncoupled from ECMO. She did well, and she was ultimately decannulated. The CP was also removed. Looking back on this case, Dr. Kapur, one of my earliest memories with you is the attending is enrolling for STEMI DTU. You did a lot of work with LV unloading pre-PCI. And I'm curious if you have thoughts about the use of MCS as a salvage here as opposed to the upfront LV unloading, similarly to what you did in DTU. So can you talk about this idea of door to unloading and what the data is showing in this population?
Yeah, no, it's a great point. And actually, in this case, the operator who was out the outside hospital also was a DTU operator when they were a trainee at Tufts. They had spent a number of years unloading those cases, and in fact, his first comment was, "I wish we had the capability to have just unloaded this patient." And that's not just excitement. He's a phenomenal operator, and I think he's also, by firsthand experience, come to recognize that when you have a patient who is unloaded, the most important thing you note immediately is that they're no longer ischemic. And this is something we learned from the LVAD literature. Once you're on pump, the multivessel and stage ischemic myopathy is really a secondary issue. The coronaries are not the primary issue anymore. So I think in cases like this, especially because of the thrombotic burden, the no reflow, those are things that would benefit from basically reducing the LV EDP while also augmenting the coronary perfusion, especially during ischemic conditions. And that's an entire body of literature that's been around for about 3-4 decades, coming from the surgical side and then translating now to the percutaneous and interventional side. The field of LV unloading is fundamentally focused on myocardial protection and myocardial recovery. And you hear that a lot, and it sounds like it's a brand marketing thing. It's not. It's actually fundamental science. So when I talked to Greg Cooper, who is our senior most cardio transplant surgeon, in his words, his first question to us when we put the patient on ECMO is, did you protect the LV? And what does that mean when he says that? What he means is did you put in an LV unloading device? He uses the term LV protection because he knows as a surgeon that when you vent the LV completely, you have a myocardium that's now at rest. Oxygen supply demand mismatch is now taken out of the equation, and you have a resting myocardium. And that sets the stage for biologic mechanisms that lead to recovery. So the DANGER trial focused on many, many, many things, far more complex because it required systems of care and everything we talked about from post-procedural management. But what you do in those first 10 minutes when somebody is coming in with STEMI and cardiogenic shock will have an impact, because even post-reperfusion, you saw that there was reduced TIMI flow. You saw that there was progressive worsening of cardiogenic shock. That reperfusion injury obviously manifests itself. And so the way this patient recovered was that essentially they had early revascularization. They had hemodynamic support with rapid escalation, including LV unloading, LV protection, with full systemic perfusion support using VA-ECMO. And that combination allowed them to recover. I think in this context, STEMI DTU is going to teach us a lot. I'm personally excited to see the data one day. We ended the trial at the end of last year, and the primary endpoint is a surrogate endpoint. It's infarct size. So really, the important endpoints are the secondary clinical endpoints of event rates, such as mortality, heart failure hospitalization, need for ICD, et cetera. So we hope to have that information out within the next year as the follow-ups continue. For the nerds here, I would really take a moment and try to dive deep into LV unloading. And your homework assignment tonight, because we're all nerds, is to put in LV unloading into PubMed and flip the arrow so that you start with the very first reference of LV unloading. And it occurred in 1973. And it was from cardiac surgeons who basically were testing the concept of LV unloading with an occluded LAD. And what they demonstrated was no more ischemia and improved myocardial recovery and less myocardial damage. So start with PubMed upside down, and then you'll come to this point, and you'll be a true nerd if you do that.
I'm looking forward to be a true nerd and do that PubMed search. It's been so great to have all of you here and really learn about cardiogenic shock, MCS strategies, the guidelines. And I'm glad this was recorded so I can go back and re-listen and soak in all the pearls from the session. And I think one big takeaway for me is that guidelines are guidelines. We have to think critically about the patients in front of us and really understand that fine print, really critically appraise the literature. And it's just a really exciting time to be in the field and think about next steps of how to move the field forward. So thank you so much for all the discussion. And before we wrap up, just wanted to open up the floor for you guys to share any final thoughts that you would like our audience to think about.
First and foremost is really a call to action to build on the exhortation that Dr. Kapur gave all of us. I heard the same a decade ago when I was in training, and it really inspired me to pursue this for my career. But our patients need our help. The index hospitalization is just the beginning of the illness journey for our patients. And so we need more data and more systems of care to establish post-shock and post-ICU clinics that look at the long-term morbidity of these patients. We have several at our own institution led by Dr. Iadissa at INOVA that patients who now have critical illness myopathy, neuropathy, PTSD, cognitive deficits are grateful for their lives being saved, but actually still are not thriving, which really ultimately should be our long-term goal. As Jaime Hernandez Montfort in our shock working group often says, our focus should really be longitudinal well-being. And I think recovery, longitudinal well-being, and the survival of our patients. Those are concepts that we really need to focus on as we head into the next frontier for the next decade of shock research.
Absolutely agree with you, Shashank. And I think we've talked about this previously, but collaborative care is going to become so important as we start to take care of these sicker, more complicated patients and cases, be it the heart failure cardiologist or critical care cardiologist. It's so important to have the full picture in mind from the initial insult, the hemodynamics, the exit strategy, all of that in mind at all times, and then reassessing that frequently to chart the course for our patients. Yeah, I'm so glad we had this conversation and cannot wait to come back for heart failure shock.
So there are actually 5 Ps that Joe Lascalzo handed to me when he was our visiting professor at Johns Hopkins. And I'll modify the Ps a little bit, but the 3 Ps that I would say are, number 1 is perspicacity. My favorite word, that's the second homework assignment, because I had to go look it up when Joe told me that, and I felt like an idiot. We didn't have iPhones either, so I had to find a dictionary. But perspicacity, thoroughness of understanding. So basically, everything we talked about tonight, if you go back and listen to this, there's an immense amount of detail. And if you want to be the best clinically, you have to know the detail. Okay, because you're going to be asked to adapt your decision-making rapidly. There's no time to make those decisions over hours and days. You've got to move quickly. So perspicacity of training and thought is number 1. Number 2 is purpose. So our purpose is clear. We're very passionate about it. That's another P. But basically, the purpose I think you guys should all identify for yourselves in cardiac critical care, interventional heart failure, cardiac surgery is really important. And if the purpose is cardiogenic shock, then you're in a great space for the next decade. And then the final P is the most important, which is the patient. When you're not sure what to do, stop and think about what is in the best interest of your patient. Forget about the finances, forget about the hospital, forget about the bed availability, forget about, I got to send it to this place or that place. Think about your patient as if they're your family. I would say you are the patient's advocate, and that's why you need to have all that perspicacity training and the way you think about it. And reach out to your colleagues, reach out to your friends. There's a massive network. You can pick up the phone and you can call any of us at any time and say, I've got a tough case. I think that's really important for us to work together as teams going forward. So it's been a real pleasure to have Shock Working Group partner with CardioNerds. I'm inspired by you all, and I'm so excited to work with you and to have you work with us at the Shock Working Group over the next few decades to improve outcomes for our patients. Thanks for having us.
Thank you so much.
Thanks so much for tuning into this CardioNerds episode. I'm Dan Amender. You can find all the show notes and linked references on the episode page. We invite you to join us in our effort to democratize cardiovascular education, bringing high-quality, engaging content to learners everywhere. You can help us by subscribing, leaving a review, and sharing this episode with your friends and colleagues. Your support fuels everything we do here at CardioNerds. And just a quick reminder, this podcast is not intended for medical advice. The views expressed on the show and site are our own and don't necessarily reflect the views of our institutions or employers. All CardioNerds content is independently planned, produced, and reviewed by our team. Stay tuned for more great conversations and exciting episodes. And now, my friends, it's time to make like an S2 and split.